these cleft palate repairs, we're really looking at a long-term outcome for speech and intelligibility, as well as just overall function of the child. So for cleft palate treatment, it really is a team approach. It's not just the speech therapist. It is multidisciplinary and ongoing. When we're talking about cleft palate treatment, we're mostly talking about closing a hole, but we also have to talk about the child as a whole. So the plastic surgeon is there to close the hole, but it's not just any plastic surgeon who can patch things together. It's someone who understands the physiology of the muscles and how they create the sling in the levator veli palatini and create the bulge for the musculus uvulae or the tensor veli palatini, so that they can create the appropriate sphincter for velopharyngeal closure, as well as opening and closing for the eustachian tubes for appropriate emptying. The speech pathologist is there if they evaluate the child before the surgery to see how the cleft palate is affecting articulation or shaping of the speech sounds. So right now I want you to say to yourself, tick-tock. If you had a cleft in the roof of your mouth at the front, would you be able to say tick-tock? And if you couldn't, where would you go in your mouth to create that t sound? The same thing for ding-dong. How could you say duh and ng without the roof of your mouth? And that's essentially what happens with these kids, is they can't shape those speech sounds because their structure is absent to help them produce those different articulatory movements. So they can't have an explosion of air. The tongue can't touch the roof of the mouth because the roof of the mouth isn't there. So they can develop compensatory articulation errors where they're moving their tongue or they're creating the sounds in their throat so that they can say what they hear. But what happens is their overall intelligibility is impacted. After the surgery, the SLP is involved for two major reasons directed at just the palate itself. Number one, because once we've closed that hole, does the child continue to produce those compensatory articulation strategies? So how can we fix that issue and get them to a more intelligible production? And second, for resonance, if we have a change in the velopharyngeal port, is that velopharyngeal port adequate enough to support complete closure of the velopharynx so that sound can be directed into the oral cavity at the appropriate times, or do we continue to have a gap and continue to have a resonance disorder despite repair to the muscles? The dentist and orthodontist work together for teeth development and tooth care. These children can have, if they're occurring with a syndrome, too many or too few teeth. They can have overcrowding of their teeth, and so the orthodontist is there once they're repairing the palate, closing that gap, how the teeth are shaping in the mouth and the placement of that. The otologist and audiologist work together for these children because they are at risk for hearing impairment because of the eustachian tube malfunctioning or not working appropriately. The psychologist and social worker work with the child and the family. Clefts can be an intimidating situation to deal with because not very many parents are exposed to infants with cleft lip or palate. And once the lip and palate are repaired, they're often not very noticeable to the naked eye, and so even if a parent knows or may be associated with someone in the community who has a child with a cleft lip or palate, they might not know that they have that. And so it is partly, the medical part of what are the resources available to the family so that they can have ongoing medical care to these children, whether or not they have a syndrome, but because they are having multiple surgeries. What it's like dealing with this situation socially with their family, explaining that situation, coming to grips with a child with a facial abnormality, and the guilt that might be associated with that, the interactions that these children might have in the future with their peers or with strangers on the street. And it can also be just the general overall well-being of the family and how they're coping with that situation. The pediatrician is there to see how the child is developing as a whole. Are they meeting their developmental milestones, and how they can be supported with that? And the geneticist is there to answer the question of how the cleft happened. And that's not only for the parents to know, but the child in the future as well. So if you think about the environmental and genetic factors that could cause a cleft palate, a lot of it falls on family or family history, and guilt can be associated with that. But knowing that cause, whether or not it had anything to do with environmental factors or things that could be prevented, can go into the counseling of the parents, not only for raising that child, but if they have children in the future, what's the risk of having another child with a cleft lip or palate? The same thing for the infant. When they grow up, they might be a typically developing adult once that cleft palate is repaired, and they want to have children. What's the risk of their children having a cleft lip or palate? So there are different types of surgeries to close a cleft palate. Typically, it's a furlough, a Z-plasty, or a VY pushback. I'm not going to test you on the different types of surgeries because we're not surgeons in this class, or maybe you are, and you're just here to explore. But overall, just know that the surgery repair and the efficiency and efficacy of that repair has to do with how big the cleft was to begin with. So you've seen that we have incomplete and complete clefts. We have bilateral or unilateral clefts, and ultimately what that leaves the surgeon with is how much tissue they can use to close that hole. If there's not a lot of tissue there, then they're going to have to recruit tissue from other areas of the mouth to close that hole, which can be more challenging and also influences the overall function of the velopharyngeal port. So ultimately in the hard palate, what they're trying to do is just, if there's a hole, we have to patch the hole, because that's an adynamic structure. It doesn't move. But if you have to repair the soft palate, you're really looking at a more challenging situation because it has to provide that velopharyngeal closure. So once they do that initial repair, for instance in the Z-plasty, they're pulling the tissue from either sides of the soft palate and creating a Z-like suture line to create that sling of the levator veli palatini. Well, if that muscle is too tight because there was too big of a gap on either side of the palate, then they might have to go in and do an additional surgery, which can include a posterior pharyngeal flap, which is what you see up here. And what they do is take just a small incision on the back or posterior pharyngeal wall, just in the mucosa, and then pull it up and tuck it into the velum to help support that sphincter closure of the velopharyngeal port. There's a sphincter pharyngoplasty, which uses the fascial pillars to recruit into the sides of the velopharyngeal port and create that closure. Or there's posterior wall augmentation, which is just an injection into the back of the pharyngeal wall to bulk it up so that the velum doesn't have to move so far. But it all goes back to how much muscle is there to begin with. So looking at this picture here, this is a unilateral cleft lip and palate. You can see there's actually a pretty decent amount of material on either side, and so they can get a decent closure. But if you're looking at a wider cleft, either in the soft palate or the hard palate, then you're going to have short muscles because they didn't have to develop into a longer length to cover the area of the palate. They just had to attach on either sides of the palate where the cleft was. So when you're pulling those muscles across as a surgeon, you can tighten those muscles because you're really extending them beyond the tension that they were originally developed to cross, which ultimately develops how much the velum can move during speech. So this is what it looks like beforehand in a cleft palate. And you can see what they've done here is just a suture down the middle to close the mucosa on either sides. But if we look at this gentleman here on the right, we have a larger cleft here and a fistula in the front of the mouth. So what they've done on him is close the gap in the back with a posterior pharyngeal flap. And then they also took a piece of tissue from his tongue to cover the fistula in the roof of his mouth. But you have to keep in mind that changing the structure doesn't fix the function, because if we have tight muscles not having to go very far, getting pulled across an even longer space, then they're not going to be able to reach far in the back to close off that velopharyngeal port. So this is an illustration of what could happen in terms of rubber bands, and hopefully this will give you a little bit of visualization. If we're looking at a normal, healthy velopharyngeal movement, then we can really stretch that muscle as far as it needs to go to seal off that velopharyngeal port. But imagine you have a short levator veli palatini because it didn't have to stretch that far during embryonic development, and you're going to stretch it across the back of the velum to close that gap. And you really have a tight tissue. It's very hard to pull back, and that can create a gap in that velopharyngeal port.